morning, everyone. I'm hoping you're all very fresh after a nice breakfast. So my name is Abi Siva, and I'm one of the breast medical oncologists at the Medical University of South Carolina. And here, my topic is to talk about first-line treatment options for metastatic triple-negative breast cancer patients, as well as sequencing and future strategies. These are my disclosures. So a quick outline, I'll start with the PD-L1 positive patients in the first line setting and talk about studies that looked at that population, and then we'll move to PD-L1 negative patients. Then we'll talk about some of the challenges we are still experiencing in this patient population. And I'll move here. Yeah, is that better? Yeah, good, perfect. Thank you. And we'll talk about some future directions. Thank you. So just to set the stage and give a little background, you can see that the survival rates for hormone-positive metastatic breast cancer patients and HER2-positive breast cancer patients is improving over the past decades. But if you look at the triple-negative breast cancer patients with metastatic disease, the survival rates are still pretty poor and sobering. And this is up to 2019. However, over the past year, since 2018, we've had newer drugs that are being approved in this setting, starting with PARP inhibitors, and then we got immunotherapy options, and most recently we have strong antibody drug conjugates that are actually changing the landscape of how we treat these patients. It's also important to consider moving the most efficacious drugs to the frontline setting, because real-world studies like this are showing that about only 50% of the patients are actually coming to the second-line setting to be able to get treatment. So a lot of patients there's a high attrition, and many patients are not even able to make it to the second line to receive treatment, especially with triple-negative breast cancer. So there's a lot of now emphasis on moving the most efficacious treatment to the earlier lines possible. So there are two TROP2-directed antibody drug conjugates that we have been tested in the metastatic triple-negative setting, and I will be talking about these two drugs in the subsequent slides. We just heard about sacituzumab govitecan. It is a monoclonal antibody to IgG1 with a topoisomerase 1 inhibitor payload. And it has the drug-to-antibody ratio is pretty decent of 7.6. Datopotamab deruxtecan is also a TROP2 ADC with a different chemotherapy payload called deruxtecan. But by mechanism of action, it's also a topoisomerase 1 inhibitor. So both these ADCs have similar type of chemotherapy molecule attached to them. The drug-to-antibody ratio is 4 here. And you also know that the dosing schedule is different for these drugs. For sacituzumab, usually we treat patients with 2-week on, 1-week off schedule, whereas for datopotamab, patients get 1 dose every 3 weeks. So let's start with the PD-L1 positive patients and talk about how do we treat them in the first-line setting and what are the most recent studies that's looking at this question. So ASCENT-04 clinical trial was a large phase 3 trial that was presented at the ASCO 2025 by Sarah Tolani. This study looked at PD-L1 positive patients with metastatic disease, and they also took patients only with a disease-free interval from curative intent therapy of more than 6 months. And they randomized patients between sacituzumab plus pembrolizumab versus treatment of physician's choice chemotherapy with pembrolizumab. And the chemotherapy choices were the usual ones that we think about in the first-line setting. It could be a doublet of carbo-gem, or it could be single-agent paclitaxel or nab-paclitaxel. It's also important to recognize that in this study, they did allow crossover from the control arm to sacituzumab when patients were having progression. And that is very important and also very commendable that the study team allowed those patients from the control arm to get SG in the second-line setting. But also it's important to consider that because you're allowing crossover, it could impact the overall survival results. So that's something we have to consider when we look at the final analysis of this study. Before we go on with the results, I just want to remind there is a parallel study currently enrolling called the Tropion Breast 05 trial. So this is with the other TROP2 ADC that we talked about, Dato-DXd, similar patient population, so PD-L1 positive patients in the first-line setting. And here they have 3 different arms, Dato-DXd plus durvalumab as the immunotherapy option. And the second arm has only Dato-DXd monotherapy. And the third arm has the control arm, which is the chemotherapy plus pembrolizumab. So I'm very curious to see how the Dato-DXd monotherapy arm is going to do, because commonly in the PD-L1 population, we are always adding immunotherapy. So this is the first time we're going to see how this monotherapy arm is going to do. This study is still enrolling, so we will be waiting for the results of that. So going back to the ASCENT-04 trial, if you look at the patient population, they were pretty well balanced between the 2 arms. About 35% of the patients are coming from de novo disease, and all the others are coming from progression from early stage disease. Looking at the progression-free survival benefit here, you can see that there is a statistically significant and clinically meaningful improvement in progression-free survival with the sacituzumab arm from 7.8 months to 11.2 months, and the hazard ratio is 0.65. So we do not have approval of sacituzumab in that first-line setting yet, but we are really hoping with this study and the results we see here, we may be seeing sacituzumab moving to the frontline setting with pembrolizumab for our patients who have PD-L1 positive disease. So now let's talk about PD-L1 negative patient population, or if someone has PD-L1 positive disease but not eligible to get immunotherapy. So at the ESMO meeting, the past ESMO, there were 2 studies that were presented for this patient population at the same session back to back. And both of these studies looked at the same, very similar population. There are some nuances we'll talk about, but overall, they both were looking at this PD-L1 negative, triple negative patient population in the first-line setting, or PD-L1 positive patients who were ineligible for immunotherapy. So in the ASCENT-03 trial, these patients were randomized between sacituzumab govitecan versus treatment of physician's choice chemotherapy. In this study, like the previous ASCENT trial, crossover was allowed. So when patients were progressing from the control arm in the second-line setting, they were allowed to get sacituzumab, and about 80% of the patients actually received sacituzumab. And even in those countries where this drug was not available, it was provided by the study. And some nuances are there between these 2 studies. One is that the ASCENT-03 trial included patients who had a disease-free interval from curative therapy of more than 6 months. Whereas in the TROPION-Breast02 trial, which looked at datopotamab deruxtecan, they did not have that limitation. Also, it's important to see what is the proportion of those patients who had PD-L1 positive disease in both studies, because PD-L1 positive patients usually do pretty well and respond well to therapy. And in the ASCENT-03 trial, that population was pretty small, 0.4%, whereas in the TROPION-Breast02 trial, they had a larger proportion of patients who had PD-L1 positive disease but were not eligible for immunotherapy, and that was about 10% of the patients. And in the TROPION-Breast02 trial, there was no crossover. So that's also, again, important when we are interpreting the overall survival results between these 2 studies. Why am I comparing these 2 studies? Because they both were presented at the same time, and they both are showing improvement in progression-free survival. So as clinicians, if these 2 drugs were to be approved in the first-line setting, how are we going to tease out, and how are we going to choose the right drug for the right patient? So that's why I'm just trying to go through some of the nuances between these 2 studies. Also, it's important to consider what prior treatment these patients received in both of these studies. So patients who got prior adjuvant, neoadjuvant therapy, out of that population, most of them got a taxane. Some did get some capecitabine and also platinums. But prior immunotherapy use was pretty small in this overall both studies. And also, it's important to look at the chemotherapy selection for the control arm prior to randomization. So the ASCENT-03 trial did allow for doublet chemotherapy option for the control arm patients. So about 45% of the patients actually received carboplatin and gemcitabine as their control arm. Whereas Tropion Breast 02 trial did not allow doublet chemotherapy as a choice, so most of those patients did get single agent chemotherapy in the control arm. Predominantly, it was a taxane in about 82% of the patients, and then some got eribulin, especially those who got a taxane in the early stage setting did get eribulin. And last but not least, you also see there is a big difference with the median follow-up time. So the ASCENT-03 trial, the median follow-up time is only 13 months, so it's a pretty immature study, whereas the Tropion Breast 02 trial had a much longer follow-up time, about 27 months. So here we see the progression-free survival benefit about these two studies. Both are showing improvement in progression-free survival compared to standard chemotherapy. For the ASCENT-03 trial, the median progression-free survival went from 6.9 months to 9.7 months, whereas for the Tropion Breast 02 trial, the median progression-free survival improved from 5.6 months to 10.8 months. So we do see the delta between these studies are different, but like I said before, the patient population was also different, so we cannot head-to-head compare the outcomes. And it's also important to look at overall response rates from these studies. In the ASCENT-03 trial, the response rate with sacituzumab was about 48%, whereas in the Dato-DXd study, the Tropion Breast trial showed that the overall response rate was about 63% in the Dato-DXd arm. But the duration of response was pretty similar in both studies, about 12.2 months. The Dato-DXd study also showed an overall survival advantage, which actually the median overall survival improved from 18.7 months to 23.7 months. So the delta is about 5 months, which is very promising with this drug. But like I said, the ASCENT-03 trial is not mature enough to report overall survival results, but they did look at something called descriptive overall survival, and the 12-month overall survival was about 75, which is similar to what they saw in the Tropion Breast 02 trial. It's also important to see what happens to these patients when they progress from the first line. So sometimes these studies are also looking at what we call progression-free survival 2, or PFS2. And that is the time from randomization to the second-line therapy progression from the second-line therapy. So the PFS2 actually was much longer for the sacituzumab arm compared to physician's choice. So when we have potentially two drugs being studied in a similar population, and if they become approved in the first-line setting, as clinicians, how do we make decisions about choosing the right drug for the right patient? So if you think the efficacy can be comparable, then we also look at the safety profile of these drugs to choose the right drug for the right patient. So with sacituzumab, we just heard a nice talk. What are some of the common side effects? Neutropenia is the biggest one, especially grade 3 neutropenia. And then also there's nausea and diarrhea. As we are using more and more sacituzumab, a lot of us are very comfortable, but the important part is to recognize those patients who are considered to be high risk for neutropenia and utilize primary prophylaxis. Because in this study, they did see about 6 deaths from neutropenia, and those patients actually were eligible for GCSF prophylaxis, but they were not offered. So that is a preventable problem. So I think that is what, as we use more and more these drugs, we need to know in whom we should use the primary prophylaxis to prevent them from getting to such an AE. With the datopotamab deruxtecan, there's a different novel side effect profile happening. So mostly mucositis is a problem with this drug. About 60% of the patients had oral mucositis, and about 8% of the patients had grade 3 mucositis. So these are patients who will be benefiting from steroid mouth rinses, or using cryotherapy, which is holding ice chips in their mouth when they're getting treatment. So we need to watch out for these unique side effects and start thinking about using prophylaxis for these patients. They also showed some unique ocular toxicities with this drug. So some patients had dry eyes, some had keratitis and conjunctivitis. Again, counseling them about eye drops having them seeing their ophthalmologist routinely. So a few different things that we have to think about when we are, planning to use datopotamab. And also, these patients will require monitoring for ILD, pneumonitis, because deruxtecan is the chemotherapy payload, and we know that this drug could cause ILDs. However, if you look at the all-grade ILD, it was only 3%, which is much lower compared to what we had seen with some of our trastuzumab deruxtecan studies. So that's reassuring. So this is a summary table that is sort of pointing out the similarities and differences between the two studies. And as I already mentioned, both studies are showing a progression-free survival benefit. Ascent-03 is not mature to show overall survival yet. Tropion-Breast did show an overall survival and higher response rate. The toxicities are very different in both with both drugs. However, both studies had only about 4% discontinuation rate, so that's also reassuring. Supportive care is going to be very different when you are using these drugs. And also the logistics. At the end of the day, patient preference and convenience matters as well. So for Trodelvy, patients will be coming twice per cycle, whereas for Tropion-Breast 02, with Dato-DXd, it'll be once per cycle. So currently, we do not have ADCs, these two ADCs, approved in the PD-L1 negative first-line setting yet. But again, once these FDA approves these drugs in that setting, it's good to know the nuances of these studies so we can select the right patient for the right drug. Beyond the first line, what are the other ADC options that we have for triple-negative patients? So we know trastuzumab deruxtecan was studied in the DESTINY-Breast04 trial for patients who have HER2-low disease. And we know about 35% of our triple-negative patients will have what we call HER2-low disease. And if you look at the DESTINY-Breast04 trial, even though it was a predominantly hormone-positive patient study, there were about 60 patients who had triple-negative breast cancer and HER2-low disease. And in these patients, there was an improvement in progression-free survival as well as overall survival with trastuzumab deruxtecan. And this led to the approval of trastuzumab deruxtecan in the second, third line setting for our HER2-low disease patients. So what about the ultra-low population? Do you think if someone has triple-negative disease and HER2 ultra-low, can we use in HER2? But this question is now being asked and studied in the DESTINY-Breast15 trial. Until we have the results, we cannot extrapolate this to that population, but hopefully that study will answer this question. So beyond the ADCs, what other options do we have for our triple-negative patients? If a patient has BRCA mutation, then we know there are two big studies that showed PARP inhibitors can improve their progression-free survival. And you can see in Olympiad, the median progression-free survival improved from 4.2 months to 7 months with olaparib. And then in the EMBRACA study, talazoparib improved median progression-free survival from 5.6 months to about 8.6 months. These studies did not show an overall survival benefit. However, when they looked at the subgroup analyses from Olympiad trial, they noted that patients who did not get any chemotherapy previously did actually show an overall survival benefit to the PARP inhibitor. So now that, how do you put this into context when you have a patient who has BRCA mutation and come to you as first-line therapy? So if the patient has PD-L1 negative disease and the option of PARP inhibitor, most of us are using the PARP inhibitor first because of this survival benefit that we saw when we are using this drug in the first-line setting. Whereas if you see a PD-L1 positive patients where we are strongly thinking about immunotherapy options up front, many times we are going with the immunotherapy chemo combination because we know that immunotherapy may not give us the same mileage in the later line setting. But we also know that the TBCRC studies looked at patients who had somatic BRCA mutation, and germline PALB2 mutation. And we also saw that there is a benefit to PARP inhibitors in those patients as well. So the expansion for PARP inhibitor is now getting wider, and we are considering these options for even our somatic BRCA patients or germline PALB2 patients. Despite all these progress that we have made, there are still many ongoing challenges. The first question is, how do you sequence when you have multiple ADCs available to your patients? How do you know which one to use first and which one to use second? And can you use them back to back, or do you have to put a chemotherapy drug in between? So these are the questions that are still being explored and studied. But some of the real-world studies that I'm showing here are telling us that when you use two ADC drugs back to back, the second ADC is really not performing well. The progression-free survival to the second ADC is very, very short. So that's a very unmet need situation. Once somebody's gone through first ADC, what do we do next is a big question. And also, this real-world study looked at patients who were previously treated with TDXD. After that, when you expose them to maybe another ADC or chemotherapy, overall, the progression-free survival in that later line setting is only 3 months or less, especially in the triple-negative cohort. So again, this is a very high area of unmet need, and we need more innovative therapies for these patients when they progress on the ADCs. And TRADE-DXd is a phase 2 trial that's ongoing in at Dana-Farber, looking at this sequencing question. So can we look at sequencing options between starting with TDXd followed by Dato-DXd versus the opposite to see if one strategy is better than the other? So this question could answer some of this study can answer some of those questions that we have about sequencing ADCs. Another challenge that we all face in clinic is those patients who are rapidly progressing after their neoadjuvant Keynote 522 regimen. And we do see those patients, like right after they complete their immunotherapy maintenance, they are coming back with recurrent disease or progression. So how do we tackle these patients? Studies are showing that the biology of this cohort is very different. They have very low amount of immune signatures in their tumor. They are very basal-like tumors, and we have to come up with a different way of attacking these cancer cells compared to the common approach that we take for everyone. And also, if you look at the pattern of recurrence after neoadjuvant therapy, these are 5 neoadjuvant therapy that are shown in the curve here. About most of the actual recurrences or progression is happening in that first 18-month period from randomization, which means about 6 months from the time they finish their curative intent therapy. So again, that is the time frame that is very critical for our patients, and we have to watch them very closely in that time frame. And this is specific to Keynote 522, and you can see about 70% of the recurrences are happening in that first 18 months. So what are some of the future directions? SAC-TMT or sacituzumab treomotecan is another TROP2 ADC that's being studied in the triple-negative as well as hormone-positive setting. This drug is already approved in China for triple-negative patients, so that we have multiple ongoing studies that are now ongoing. We have in the United States. Something novel that we are all very excited about is these bispecific antibody-drug conjugates. So Isabren is a molecule that's targeting EGFR and HER3, and it has a chemotherapy component attached to this monoclonal antibody. So this is, again, a drug that's now moving to larger phase 3 trials in the triple-negative setting. Emi-Le is another novel molecule that's targeting something called B7H4, and this is an antigen that's commonly expressed in triple-negative breast cancer. And they have a very unique chemotherapy payload, which is a microtubule inhibitor. So far, all the ADCs that I have discussed, they all have a topoisomerase 1 inhibitor payload. But this is one of the ADCs that's coming up with a microtubule payload, and we are again excited to see how this drug is going to perform in large studies. So I also want to point out to this molecule before I end my talk. Pumitamig is a novel bispecific antibody that is now targeting the PD-L1 and VEGF. And the rationale for that combination target is because PD-L1 is expected to reverse immunosuppression of the T cells, whereas the VEGF component will improve the vascularization, improve T cell infiltration, and also decrease regulatory T cell proliferation. So based on this hypothesis, this molecule is now also showing promising activity and moving to large phase 3 trial. And the Rosetta Breast one is the first study that's looking at triple negative, PD-L1 negative patient population with this compound. And also, last but not least, androgen receptor blockade is also something important to think about. We know about 20 to 40% of our patients with triple-negative breast cancer will have androgen receptor expression. So identifying those patients and offering them treatment is important. Again, we don't have a lot of promising activity with androgen receptor blockers from the small studies we have, but there are multiple ongoing studies like this one that is looking at that question. And I'll stop right there and happy to answer any other questions that you have.
Thank you, Dr. Siva. Does anyone have any questions for Dr. Siva? No? Okay, if they do, they can catch you after break or catch you outside here to ask those as well. Up next, I'd now like to invite Dr. Teplinsky from Valley Health up to the podium to present on sequencing treatments for HER2 positive disease.